lynch brace suture. Okay, so scenario is that a grand multipara um, had normal delivery, and you did medical treatment, but that failed. You took patient to the theater and you perform examination under anesthesia, but the uterus is still not contracted. You use the balloon tamponade, but that also failed. So what would be your next step? The answer is that my next step would that be lynch brace suture. So define lynch brace suture. These are the suture applied externally to the body of the uterus in various pattern involving either upper or lower segment or both, so as to act as a brace to facilitate uterine contraction and retraction by their compression effects. What are the indications of lynch brace suture? Okay, when there is major PPH, for example, due to any uterine atony, placenta previa, placenta creta coagulation, placenta abruption, DSC, or cavalier uterus. And secondly, as a prophylactic use in the high risk patient, for example, high multiple over-distended uterus, twins, polyhydramnia, macrosomic, or multiple gestation. And thirdly, when the conservative medical methods are unsuccessful and where the uterus has to be conserved. What are the types of the lynch brace suture? We have the vertical sutures, the square suture, transverse suture, U suture, and the figure of the 8 suture. The vertical sutures includes the lynch, and the square suture includes the Afroni. The transverse suture include Kohaba, Guahpa, and U sutures include Hakithal, and the figure of 8 sutures, single figure of the 8 or multiple figure of the 8 suture. Okay, so how would you go for the lynch brace suture? First of all, I will place the patient in Lloyd Davis position and pass. I will make sure that the indwelling catheter has been passed, urinary catheter. Then I will give the pharyngeal incision of this patient, and I will lower uterine incision. I will give the lower uterine incision after dissecting of the bladder or remove the suture of the recent cesarean section. Then I will evacuate the uterine cavity and swab it thoroughly. I will exteriorize the uterus and check to identify any bleeding point. If the bleeding is diffuse, such as in case of the uterine atony or coagulopathy, or profuse, such as in case of the profuse placental bleeding, as in case of the major placenta previa, placenta creta, or in creta when no obvious bleeding point is observed, a bimanual compression is then first tried to assess the potential chances of the success of the lynch suturing technique. For a major degree of the placenta previa, it is suggested that an independent figure of the 8 suture or square sutures are placed in the lower segment transversely, anteriorly, posteriorly, both prior to the brace suture application. If necessary, the vagina is swabbed out to confirm adequate bleeding control. Now, if the bleeding is controlled by bimanual compression, then the procedure will work as follows. First of all, I will take the 70 round-bodied hand needle on which the chromic catgut number 190 cm is mounted, and that is used to puncture the lower uterine segment 3 cm from the left interior edge and 3 cm from the lateral margin. This approach is suggested for a surgeon standing on the patient's right side. The suture is then threaded through the uterine cavity to emerge at the upper incision margin 3 cm above and approximately 4 cm from the lateral margin, and this is then fed anteriorly and vertically over the fundus to enter the posterior uterine wall into uterine cavity at the same level as the upper entry points. The suture is then pulled under moderate tension, assisted by the bimanual compression exerted by the assistant. The suture is passed back posteriorly through the same surface marking as that for the left side, and the suture is now lying horizontally in the uterine cavity. The suture is fed through posteriorly and vertically over the fundus to lie anteriorly and vertically, compressing the fundus on the right side as occurred on the left side. The needle is then passed in the same fashion on the right side through the uterine cavity and emerged out approximately 3 cm anteriorly and below the lower incision margin on the right side. Then the two lengths of the sutures are pulled tightly, assisted by bimanual compression to minimize the trauma. The vagina is swabbed out by a second assistant and checked to ensure that the bleeding is controlled. The lower transverse uterine incision is now closed in a normal way in 1 or 2 layers. Vehicle number 1 and appropriate covalent suture. Ensure the good hemostasis is secured whilst the uterus is compressed by the first assistant. Place the surgical knot, and if there is uncontrollable bleeding from placenta previa, then the figure of the 8 monocrel number 1 suture is placed transversely anteriorly posteriorly. Okay, through length. The uterus is checked that tension distribution is evenly spread before placement into abdominal cavity and the abdomen is closed. Then I will ask the second assistant to remove and sew about the vaginal clots. And then be careful for vaginal bleeding and the vitals. Examiner question: which position is to be made for the lynch? I would prefer the Lloyd Davis position or modified frontline leg position, because in these positions the feet are higher than the body, and the head is tilted by 15 to 30 degree, and this position significantly improves the blood pressure and lower the cardiac output, and also it makes the exercise easy, and it avoids the injury to the nerves. What is rigid Heyman or modified Wheeling suture? In the Heyman suture passes directly from anterior uterine wall through the posterior uterine wall. 2 to 4 longitudinal sutures are placed, and a straight needle full length thread is used for each suture. A transverse cervical isthmic suture can also be used if necessary, and tied up simultaneously while asking the second assistant to squeeze the uterus. The complications include failure, slippage or slipping of the suture material cut through, ischemic necrosis of the uterine wall, the cervical trauma, hematoma, pyometra, and injury to the bowel and the bladder. What is the difference between the B-lynch and the modified B-lynch? The B-lynch suture requires expertise, while modified B-lynch suture is easy to perform. And in the B-lynch, transverse lower uterine segment inseam is required, and in the modified B-lynch, lower uterine segment inseam is not required. The B-lynch is time consuming. The modified B-lynch is less time consuming, can be completed in 2 to 3 minutes. There is cervical stenosis in the B-lynch. There is no stenosis in the modified B-lynch. There is hematoma formation in the B-lynch. There is no hematoma formation in the modified B-lynch. And in the B-lynch, there is bleeding from lower uterine segment due to multiple bites, and in the modified B-lynch, no bleeding from lower uterine segment.